mandibular expansion. Is that possible? When we do cone beam evaluations, we find that mandibles tend to dentally alveolar compensate for insufficient maxillas. And the majority of people who have crowding on the top have big, broad basal bases of mandible, but really, really steep curves of Wilson to compensate. What are we doing? We're unraveling and leveling, aligning. And we're doing that with the understanding that the limit to maxillary expansion is a squashed up lower arch. So we're taking that limit off the table and we're correcting the lower arch so that we can get the most of the upper arch. So 40 years of Swartz usage has shown this works. This creates space so that we don't have to extract teeth. And for some reason, you gain a few millimeters of AP correction in class 2. If you do both arches, you get a better sleep disorder breathing outcome. Quote in 2017 in a real journal, not just a Mickey Mouse dental journal. This is a medical journal. 4 decades of studying this gives us evidence to do mandibular arch expansion in young children. It unravels so much more because you don't run into the Brody bite, trying to fit the front teeth in on the top. If you don't do anything with the lower arch, you have to extract. You have to. There's no other option if you want straight teeth. There's a huge difference between making it work with 1 arch versus 2 arches. So this is just my protocols. We have wires at the front and the back, and it's designed to keep the appliance stable, retentive, good resistance form. We are just leveling and aligning. We have wires that control intrusion rates and eruption rates. We have wires that can shuffle teeth around in translation, not just tipping. We have the capacity to shift midlines if we have asymmetry from, say, early loss of the C. We combine that with limited fixed braces if you don't have skills on wire bending. Right? There's no reason why you can't put some brackets on the front to help you along. We're looking to anchor off the ears. When we do that, this is almost like a fixed point in space, right? Ears act as ankylosed teeth. They don't move. They don't over-erupt. So we can intrude adult teeth off ease if we want to close an open bite. It's possible. We intrude the 6s to the same level as those incisors are hanging up there. Then we extract the primary teeth and we get an auto rotation of the mandible. All right, so we have different appliances to achieve different goals. We play with all the tools that are available. if you get really good at wire bending, when teeth come through, they are on the move and you just need to nudge them a teeny tiny little bit. There's a martial arts, Japanese martial arts called Aikido. And all you're doing is using your opponent's momentum to redirect them. So teeth have momentum when they're erupting. You just give them a little nudge and they shift course immediately. You put it at the center of mass and you can move the whole tooth as one. Plus, there's no root tip, right? Because they're brand new teeth that haven't closed apexes. So you sit that wire right on the gingival margin and you can translate it. I've translated it 8 millimeters, pure translation. If they come through in the wrong place, you just put a, you can't come here anymore. And then they go, fine, I'll go there. But only when they're erupting. Is it that easy? AP, everyone wants to know, well, you know, the screw does all the widening. How do you do the AP? Here's the secret. Everyone open your mouth. All right. Where's your chin? Down and back. Everyone close your mouth. Where's your chin? You just lost some class 2, right? Open your mouth. Class 2. Close your mouth. Less class 2. That's it. When you're growing, your chin just grows in the direction it's pointed. Do you want it to grow as a class 2 open bite, or do you want it to grow as a class 1 regular bite? Keep your mouth shut. Tracks on the same plane as the maxilla. Hang your mouth open. It's got its own path. That's it. What if the maxilla is behind? Pull it. All right, we just use our plate. You know how today we've worked out TADs work much better than brackets when we're trying to do mechanics, yeah? Oh, a block of plastic that's locked in to the whole upper arch, is that the same as a TAD? Pretty much. So Enrico builds a little hook and you just hook your elastics onto it. That's it. Do we know that it works? Yeah. One Moon and Nagan are heads of departments. They do heaps of stuff on class 3. And we know Asians in particular have short cranial bases. So it's really a big issue and you got to deal with it really, really early. There's all sorts of masks, you know, Sandra Khan's got her bow but you know, when they're little, anything and everything works. All right, but every time we pull, it goes down as well. So how do we overcome this? Well, we tried to use TADs and that works, but it still goes down and forward. Everything you do increases vertical. That's just life. So we know if it's done with thought, we can prevent 80% of the children from needing surgery. If we start early enough, 7 to 9, we can prevent 2/3 of the kids from needing surgery. And there's another quarter that you can do camouflage, and it's only a small percentage at that point that you need surgery. But you leave a class 3, a true class 3 grow, you want it fixed at 13, come back at 18 and we'll do surgery. That's it. Can we do anything to pull a mandible forward? We know we can pull the maxilla. And again, open your mouth. Where is it going? Close your mouth. Where is it going? All right, the body responds to pressure and momentum and consistency. Keep your mouth shut. Like, who wakes up in the morning and thinks, my bite's different? And then who by morning tea thinks, oh, there we are. Stuff's been moving at night. And you're all grown up and it moves. But when you're little, lots of stuff happens overnight. We're not making it up because we've got a head of a major teaching university who says, I've been doing this for 40 years and it works. You know, when people say you're making this stuff up, you say, no, actually, there's a head of a major teaching university who's been doing this for 40 years and he says it works and he's done real research. You show me the paper where it doesn't work. And I'll show you the class 2 paper that says that most of what you do isn't evidence-based. Rotation. This is the secret of how chins grow. The top jaw grows first, the bottom jaw lags behind. Do you know why? Ever given birth to a class 3 baby? Things break. Or you need the head, the biggest part. Can't have a jaw bigger than the head. All right, so that's just life. Ever tried to breastfeed as a class 3 baby? I don't know, but I don't think it works. All right, there's anatomical needs at different points in your life. The maxilla grows first. The mandible catches up, right? Maxilla stops at about 11, 12. The mandible keeps going 16, 21. That's how things are supposed to be. Rotation. True rotation is how the chin goes from a baby face to a grown-up face. And true rotation is driven by posture, closed mouth resting posture. The same thing when I ask you to open, all the muscles pull your chin down and back. Then I ask you to close, all the muscles pull your chin up and forward. That's how we grow. And it actually happens mostly between 6, 7, 8, 9. Six, 7, 8, 9. That's when most chin growth occurs. We know this for a fact because it's been researched.